F1, yep. Okay, so now I think we're fine. Yeah, Adam can hear us. So.
Let me know when I should start. Okay. Oh, they got it.
Guys, swipe down.
Should I just go ahead and
Yeah.
start?
Guys, we're gonna get started. I know you're still grabbing food.
Can you hear me over on the Brigham side? Should I just go ahead and start? Okay. Um, so the topic that we're going to address today is medical treatment of Parkinson's disease. And one of the things that is most rewarding and satisfying about treating Parkinson's is that unlike many of the other neurodegenerative conditions, there are actually more and more medications that are actually very effective. And it's a matter of trying to find the right medicine or combination of medicines that you can use to most optimize a patient's mobility and their quality of life. So I'm just going to have one slide just to talk about evaluation, because all of the rest of the slides are going to be discussing a patient who you feel convinced has idiopathic Parkinson's disease. And so this is not about diagnosis. We've talked about that before, but obviously, especially for a patient who doesn't already come in with a diagnosis of PD or somebody who has some atypical features, you first want to confirm the presence of the cardinal Parkinsonian signs: tremor, rigidity, bradykinesia, postural instability. Be confident that you've excluded secondary causes of Parkinsonism, including drug-induced forms of Parkinsonism, any structural abnormalities that might be contributing to their symptoms, or any toxic explanations for their Parkinsonism. And in regard to this issue, think about whether or not you need any confirmatory imaging, either in terms of an MRI to rule out any structural contributors, or if the diagnosis is in doubt about whether or not a person has neurodegenerative Parkinsonism, thinking about whether there's any role for dopamine transporter or DAT imaging. We'll get to that in a minute. So Alice was asking about whether or not a therapeutic trial would also be appropriate, and that's definitely, I think in many cases, is appropriate. You also want to just assess for any atypical Parkinsonian features that are listed here. And this is really trying to distinguish a patient who has idiopathic PD from other forms of Parkinsonism. Now, all patients who you suspect have Parkinsonism deserve a trial of dopamine replacement. And the reason why I lump this together is that if you think or are uncertain whether or not a patient has idiopathic PD, the best thing to do is just to try levodopa. Don't try any of the other medications, because if there's no response to an agonist or an MAO inhibitor, you don't know whether or not the dose you have is appropriate or whether or not it's somebody who just needs a more potent medication. So when a diagnosis of idiopathic PD or atypical Parkinsonism is in doubt, it's certainly appropriate to try to help in terms of your diagnosis by using a trial of dopaminergic therapy. And I would just recommend sticking with levodopa in these instances. The last thing is also for patients who either have idiopathic PD or other forms of Parkinsonism. You do want to remember not to overlook non-motor symptoms. Anxiety, depression, sleep disturbance are often early symptoms of Parkinsonism, and in many cases, these can be as limiting to a person's quality of life as many of the motor symptoms that we're going to mostly address today. So this is a list of some of the medications that are now available to treat the motor symptoms of Parkinson's disease. Levodopa, which comes in multiple formulations, some of which are fairly new, and we'll get to those later. A variety of dopamine agonists that come both in oral forms and in patch forms, and are now marketed both in immediate release and extended release formulations. COMT inhibitors, and entacapone, which is used fairly often for people who start to have motor fluctuations. Tolcapone or Tasmar is, I think, still available on the market, but it's now rarely used because of the risk of hepatotoxicity. There are a couple of MAO-B inhibitors, anticholinergics, and amantadine. And when you see a patient with idiopathic Parkinson's disease, you have all of these options at your disposal, and you want to give some rational thought to why you pick a certain agent. And so as we go through some of these, and we're doing this in a case-based way, as you think about these cases, and as you see patients with Parkinsonism, the one thing I really want to stress is always think about what you're trying to accomplish with medications. What symptom are you trying to treat? What change in a person's quality of life are you trying to make? And then think about how your medication steps are going to help achieve that goal. So here's the first case. This is a 46-year-old right-handed gentleman who presented to the office referred by the primary care physician with an 8-month history of decreased left-hand dexterity and mild left thumb tremor. At the time, he was still working full-time, didn't have any significant limitations in his day-to-day activities. He had no significant past medical history, nor was he taking any medications. His family history was notable for a maternal uncle who had dementia with Lewy bodies developing in his 70s. And on exam, he has a slight intermittent left arm rest tremor, mild rigidity and bradykinesia on that side, slight degree of decreased facial expression and hypophonia. His gait was normal, with the exception of having decreased arm swing on the left side. So this is a very typical presentation of somebody who is about to be diagnosed with idiopathic Parkinson's disease. So what to start? The first thing that you're going to do in this visit is to explain the diagnosis to the patient. Explain to him why he has symptoms that make you suspicious that he has idiopathic Parkinson's disease. If you can, convince him that this is not something that we're going to do testing for, and then talk to him about where things move forward and what the treatment options are. So here's a list of possible options. You can make the diagnosis and not start anything. You could suggest starting an MAO inhibitor, an anticholinergic, or dopamine agonist or levodopa. So quick show of hands. Who wants to hold off on starting medication? A handful of people there. MAO-B inhibitor? Shanique wants to start an MAO-B inhibitor. Anticholinergics? Okay, or how about dopamine replacement? Either dopamine agonist or levodopa. Okay, some people want to start that. Okay, Alice would start that. That's one of the lessons here. There is no right answer to many of these questions. So, taking care of Parkinson's disease, there's not one right way to do it. And again, the way that you may treat it may be different than somebody else, but the most important thing is that you think rationally about why you're picking the medication you would choose. So what I would do is I would probably either hold off on medicine, start an MAO-B inhibitor, or if the tremor were very severe and limiting, which his isn't, but somebody might have a tremor predominant form of Parkinson's, to think about anticholinergics. And it would be my practice to hold off on dopamine replacement in this patient. And the rationale for that is that current treatments for Parkinson's disease are symptomatic. So even though this patient has a little bit of bradykinesia and tremor, it's on his non-dominant side, he's told us that it has no bearing on his day-to-day activities. So what are you trying to accomplish? What are you trying to treat? Are you trying to treat a little bit of bradykinesia and rigidity that don't limit the patient? Or are you thinking that it should be limiting him more than he says it does? And there often can be a disconnect. Somebody can be very bradykinetic and say that it has no bearing on their day-to-day function. and it's part of your role to try to assess that. But I would say this gentleman, at least the way that I've described him, he only has a slight degree of rigidity and bradykinesia that aren't limiting. Well, there is a discordance between what a patient reports to you and what you sense on exam. So if somebody really is slow in their movements and you're watching them and they're having a lot of trouble with finger tapping, then I think that it is your role to step in and say, even though a patient subjectively is not complaining of symptoms, the way that you see his exam, it's likely that it is interfering with his day-to-day activities. But just for the sake of this case, let's assume that this patient really is doing well, and the reason that he came in was for diagnosis, and if not for his primary care doctor's observation that he had a little bit of thumb tremor, he probably wouldn't even be there. So the main question about MAO inhibitors really revolves around one large study called the Adagio study, where patients with early Parkinson's disease, newly diagnosed, not on other treatments, were randomized to receive rasagiline versus placebo. And one of the challenges in doing neuroprotection studies is that many of the medications can have some mild symptomatic effect. And so when you try to dissociate the symptomatic effect from the disease modifying effect, it may not always be easy. So for the purpose of trying to answer that question, this delayed start design was used for this particular study, where some subjects were randomized to placebo. Well, all subjects were randomized either to placebo or rasagiline at the beginning of the study. And then after 9 months, subjects that were on placebo were then started on rasagiline. So the argument is that if you follow them for a period of time, the symptomatic effects should even out. Whether a person's been on rasagiline for 9 months or 18 months, the symptomatic benefits should be similar. So if there is an effect in terms of altering the course of Parkinson's disease, one would argue that those patients who are started at the very beginning would somehow be better off than those who started it later. This was a very large study, almost 1,200 subjects. They were followed for about a year and a half. And the prediction is if there is a disease modifying effect, at the end of that period, there should still be a statistically significant difference between those started at the beginning and those started with a delay. And this figure at the top shows the difference between the two. Those patients who were started on rasagiline initially had an improvement in their Parkinson's symptoms, presumably to a mild symptomatic effect, and then gradually over time, maintaining the same dose, their Parkinson's gradually progressed. Those who had a delayed start initially continued to have some progression. When their medication was started here, there was a little bit of improvement, and then again, they gradually got worse. And at the end of the trial period, there was still a difference between those who began at the beginning and those who had the delayed start. And just taken at face value, one could argue that that means that early treatment is good, possibly neuroprotective. Now, what was interesting is that this lower slide uses a higher dose, 2 milligrams. And again, there was some improvement at the beginning, but at the end, there was no difference between the two. And so there are multiple ways that one can interpret these data, which we're not going to get into the details of here. But it is a little bit disconcerting if there is a very strong effect that taking less medication would not give you the same statistically significant result as taking a lower dose. The other issue in interpreting these data is to think about whether or not the difference is actually statistically, well, even though it's statistically significant, is it physiologically meaningful? So the rating scale here is a UPDRS, Unified Parkinson Disease Rating Scale. The difference at the end of the study was about 1 or 2 points. Does that mean anything clinically? And so for a number of reasons, the role of rasagiline in disease modification is still controversial. You will see some Parkinson's specialists who feel that everybody who is newly diagnosed with Parkinson's should be placed on misagiline. You'll see others who feel that the evidence is not strong enough to warrant anybody being put on misagiline. And then there are many people who will fall somewhere in between. Correct. So they've been followed for a longer time now. There's been extension studies done, and it hasn't really clarified the data any further. So if you are thinking about treating early Parkinson's with dopamine-sparing therapies, MAOB inhibitors are certainly a possibility. They do have mild symptomatic benefits, and it's for that benefit that the FDA has approved its use. The FDA did not approve its role or a change in its labeling as a neuroprotective agent. If you're going to use this medication and you believe the neuroprotective effect, possibly that should be another rationale for thinking about putting somebody on it. And I'll have to admit that if I see somebody in their early 30s or even somewhere in their 30s and 40s who have some mild symptoms that not really bothering that much, but maybe a little bit, I might think about using misagiline because of the possibility that if it has any neuroprotection, you want to think about it in somebody who has young onset Parkinson's disease. There is a theoretical concern about interactions with tyramine, although in clinical trials, that's not a big concern with MAOB specific inhibitors. There's also drug-drug interactions, and that's something that's important to think about, especially if a person with early Parkinson's has some anxiety and depression and they're on SSRIs. So not a strict contraindication, but if they're on a fairly high dose of those medications, it's worth thinking about. Anticholinergics are most effective for treating tremor, less effective for bradykinesia and rigidity, and you always have to think about possible anticholinergic side effects, especially cognitive ones. And so I tend to avoid anticholinergics in patients who are older. Young onset Parkinson's who may have a fairly prominent tremor, but aren't limited by their bradykinesia or rigidity. It is at least an option to think about using anticholinergic medication. The other way to approach dealing with a patient with young onset Parkinson's or even early onset Parkinson's, early symptoms of Parkinson's disease who don't yet need medication is to think about whether or not they have any interest in participating in clinical research trials. Neuroprotection trials are mostly geared towards patients who are not yet on dopamine replacement, because once a patient starts dopaminergic therapy, it confounds your exam and the way that you monitor Parkinson's progression. The one active clinical research trial right now is radipine, which is an FDA-approved calcium channel blocker, which has been shown in vitro to have effects in terms of reducing the vulnerability of dopamine neurons. It's been studied in phase 2 studies. It's safe. We're doing a phase 3 study now. An approach that has really been spearheaded by Michael Schwarzschild in our department, along with Alberto Escario at the School of Public Health, is modifying the serum levels of uric acid. Urate levels seem to correlate with the rate of PD progression in patients with early Parkinson's disease. At this point, it's not clear whether or not the higher urate level is somehow protected in and of itself, or if it's just something correlated. But you can use inosine, which is a precursor of urate, patients can take that. It elevates urate levels in the blood and in the spinal fluid. And hopefully within the next year or so, there's going to be a phase 3 study trying to assess its efficacy in terms of slowing down Parkinson's progression. There's also a number of trials that are now in phase 1 that are directed against alpha-synuclein. And these really are using the same approaches that have been used for Alzheimer's disease, where you're using immunotherapy. This PRX002 compound is an antibody versus alpha-synuclein, which is given IV, so it's passive immunization. And in healthy individuals, it's very effective at clearing serum alpha-synuclein from the blood, whether or not it has any effect in the spine, in the CNS, or whether or not intervention for people who are already symptomatic is going to be effective, we don't know yet. And then there's also another vaccine approach, again, along the lines of what has been used for other neurodegeneration. All right, so this is the next case. This is a 52-year-old right-handed gentleman who presents with a 3-year history of progressive slowness, change in posture and balance, and mild tremor. He still describes himself as fully independent. He doesn't need help from anybody in terms of dressing, but he does note that it's more difficult to do buttons or to handwrite, and he now has some trouble getting out of a car. His past medical history is notable for some hyperlipidemia, where he's not requiring any medication, as well as some mild anxiety. And his exam is notable for mild to moderate rigidity, right greater than left, mild bradykinesia with right finger tapping and pronation supination. He has a decreased facial expression, and his gait is a bit shuffling, although he doesn't have any retrocussion. All right, so here you have the same choices again. Hold off on medication, show of hands. MAOB inhibitor, anticholinergic, dopamine agonist. Few people, levodopa. More people. Okay. So I think there are any of a number of options, and I'm going to show you some results from a study that was just published last year that suggests that in the long term, it probably doesn't matter what you pick. The results are likely to be fairly similar. But you want to, again, have a rationale to why you're picking a certain medication. Think about starting dopamine replacement when the motor symptoms are starting to limit daily function. There are some patients and some doctors who take the approach that they're not going to treat as long as the patient still is able to get around. Okay, I tend to be a little bit more aggressive. I think along the lines of what Dr. Flaherty was saying earlier, you can make a big difference in a person's quality of life. This is a 50-something-year-old gentleman who's still working and is now limited by his symptoms. And you can make a big difference by starting them on medication if they have idiopathic PD. All right, so this is often the question. If I'm going to start dopamine replacement, what am I going to pick? Am I going to pick an agonist, or am I going to pick levodopa? And so what we have to do is we have to draw on trials that were done now about 15 years ago, comparing agonists to levodopa before the dopamine agonists were FDA approved and really kind of became part of our armamentarium for treating PD. So these are two of the important studies. The one on the left compares pramipexole with levodopa. The one on the right compares ropinirole with levodopa. Both of them enrolled somewhere in the range of about 300 subjects. The pramipexole study followed patients for a duration of 2 years, and the ropinirole study followed them for a longer period of time. On this graph, the pramipexole is the top line, and the levodopa is the bottom line. And this is looking at total UPDRS, which includes questionnaires about activities of daily living. And the bottom one is just the motor scale, what you see on the exam. What you see is that both of them give an initial improvement in Parkinson's symptoms, both in terms of their motor subscale and in terms of their overall UPDRS. Levodopa is better than agonists, and that persists for the duration of the treatment. Now, in these particular studies, they didn't adjust the dose, and that's obviously something that's different than what you do in real life. So in real life, you're not bound to stay on the same dose for the entire treatment. You can adjust the dose, you can combine medications, but for the clinical trial, you were on a dose and you stayed on it. So the same holds true with ropinirole and levodopa. And if you look at other dopamine agonists that we really don't use that much here in the United States anymore, medications like pergolide, bromocriptine, cabergoline, the result always is pretty consistent, that levodopa is better at treating the motor symptoms of PD than a dopamine agonist. So selection of the medication partly depends on what your goal is in terms of treating symptoms, but there's always this risk-benefit ratio in terms of thinking about side effects. And between those two medications, dopamine agonists are more likely to cause short-term side effects than levodopa. This is a list of some of them, and it's important when you're prescribing these medications to make sure that your patients are aware of them. Nausea is a pretty common symptom early on, and it can happen at fairly low doses of medication. There are reports of patients having excessive drowsiness or daytime sleepiness. Even some patients who take these medications and fall asleep at the wheel, not because they're developing any kind of narcolepsy syndrome, but just because it makes them tired. And if you're not aware, this can happen. So it's important that patients are aware of that. Confusion or hallucinations generally is less of an issue in early Parkinson's disease than it is in more advanced PD, especially in older patients who have some cognitive issues to start with. And then it's important to inform your patients that they may develop some issues with impulse control. Now, a couple of slides to talk about that. Impulse control disorders and Parkinson's disease is becoming more and more recognized. The one that's gotten the most press is pathologic gambling, but patients can also develop hypersexuality, compulsive buying, binge eating. And if patients are not told that these are side effects of their medication, these aren't the kind of side effects that, in my experience, people are likely to report to you. There are a number of risk factors for developing ICDs: younger age, longer PD duration, if there was any history of any gambling or hypersexuality before the Parkinson's. Amantadine can also increase the risk. Patients who are unmarried seem to have that problem, and whether or not that's because you have somebody who's there to monitor you, I don't know. I don't know the specific mechanism for that. Also, if there's a family history of gambling problems, that does seem to increase the risk that you'll have these kinds of issues, even if you've not had any gambling before. I don't know, maybe, yeah. So the largest cross-sectional study looking at ICDs in Parkinson's disease was published about 5 years ago. And this looked at over 3,000 patients with treated idiopathic Parkinson's disease at movement disorder centers. About 1 in 6 patients had an ICD. Majority of them were gambling, buying, but you also see some of the others. And they don't necessarily happen in isolation. About a quarter of those who had one impulse control issue had another as well. Men were much more likely to have compulsive sexual behaviors by about 10-fold. Women were a little bit more likely to have issues with compulsive buying or eating. And again, as I mentioned before, you had a higher rate of ICDs if there was a first-degree relative with a gambling problem. Now, this table is interesting because it compares subjects based on whether or not they were on a dopamine agonist or not. And if you look comparing these two numbers, one on top of each other, for each of the different ICDs or for any ICD, you see a consistent effect that there's about a 3-fold increased likelihood of developing an ICD if they're on a dopamine agonist compared to if they're on some other medication, but where their regimen doesn't include an agonist. Comparing pramipexole and ropinirole, there's really not a big difference. And so I think that some physicians who really feel strongly about using an agonist may try, if one of them seems to induce an ICD, trying lower doses of a different ICD. I personally, if it's a big problem that is enough to make you stop or cut down on an agonist dose, I personally don't switch to another one because the likelihood that they're going to achieve higher doses of the other one, I think, is pretty low. All right, so getting back to the issue of dopamine agonist and levodopa, what I told you so far is that a levodopa is more effective. Dopamine agonists have more short-term side effects, including nausea and impulse control issues. So it raises the question, well, why don't you just put everybody on levodopa? And the main rationale that I think some people hold to more than others is that if you look at long-term motor complications of early levodopa treatment, starting levodopa early seems to increase the risk for motor fluctuations and dyskinesia. And again, this has been true of all of the various agonists. Here I show you the results for pramipexole and ropinirole, but the same was true for older agonists. And I think that the likelihood is that this is probably something real. We're not going to get to the mechanism of why this is the case, but if you just look at the numbers, let's say for the agonist, the patients who were randomized to levodopa early at the end of the study had about a 1 in 3 chance of developing dyskinesias, where there was only a 1 in 10 chance with the agonist. The difference was less for ropinirole, and again, the numbers here are higher because the duration of the study was longer. But in either case, there was a clear increased incidence of developing dyskinesias if you were randomized to levodopa at the start of the study. And that includes wearing off dyskinesias and on-off fluctuations. So As I think about weighing whether or not to start an agonist or starting levodopa, these are some of the things I think about. Some of the issues that might put you in favor of starting an agonist are younger patients, if they have lower comorbidities in terms of blood pressure issues, especially cognitive issues, you might tend to starting an agonist. On the other hand, an older patient who has comorbidities or has any cognitive impairment, I think that you're better off just starting levodopa. So just want to use a couple of slides to be very practical and think a little bit about how to start medications. Because it's one thing just to say, okay, well, I'm going to start an agonist. And then you also need to think about which agonist you're going to start and how you're going to start it and what dose you're going to achieve. It's not that unusual for a patient to show up at a movement disorders center saying that they failed dopamine agonists, and you look at the dose, and the dose was so subtherapeutic that it doesn't surprise you at all that there was no benefit. So the three choices are pramipexole, ropinirole, and rotigotine. The first two are oral. This one is a patch. I've kind of given you a rough effective dose. I think that the last dose is the maximum recommended dose by the company. The lower dose is, you can go lower than that, and for some patients that may be enough, but I would at least try to work up to a reasonable dose before you conclude whether or not the agonist is or is not effective. The other thing to think about is the relative potency. So ropinirole is the one where you have to take the most milligrams in order to get the same effect. For pramipexole, it's roughly 1 in 4. So if you take the total ropinirole dose and divide it by 4, you get roughly the equivalent of pramipexole. And rotigotine is about 1.5 to 1. So if you have a dose of 3 milligrams of ropinirole, that's roughly 2 milligrams of rotigotine. With the regular agonists, the immediate release forms that have been on the market now for more than a decade, most of the time people tend to dose them TID, and you gradually work the dose up over time. Don't start them on the target dose right away, because likelihood is that as soon as you do that, you're going to get a call that person is feeling nauseous or they're sleepy. So just gradually work it up over a period of weeks and then try to get a sense of what the response is. There's really no difference between the two. There's some difference in terms of the metabolism, but neither of them have to really be dose adjusted based on kidney or renal function. It's really dose based on symptoms. So you can really just pick one or the other. And then the question is, well, there are now these extended release forms. The pramipexole and ropinirole ER forms are marketed as once-a-day medications, although oftentimes they may last only 12 to 18 hours. The rotigotine patch, you change every day. And there's not a lot of good studies that compare the immediate release with the extended release forms in terms of its efficacy. Obviously, from the standpoint of the pharmacokinetics, the extended release forms are easier to take. Patients are likely to be more compliant with it, but they also tend to be much more expensive. And so you have to weigh that into your thinking. I still personally, for most patients, will start an immediate release form first. And then if there's some issues, either with peak dose side effects or with compliance, then we'll go ahead and fill out a prior authorization to try to get them the extended release form. A word about carbidopa-levodopa dosing. And this is something that's really important as a neurologist to pay attention to. There are different formulations of carbidopa-levodopa or Sinemet, and they don't work the same. So don't make the error of ordering one medication, whether a patient's coming into the hospital or if you're writing a prescription. If a person is on controlled release and it's working, keep them on the controlled release, or at least if you're going to switch them, make sure it's because that was intentional and not because of a prescription error. There are different formulations of immediate release that vary depending on the amount of carbidopa and levodopa. The 10-100 has been around for quite a long time. I personally never use that. The 25 milligrams of carbidopa given 3 times a day gives you a total of 75 milligrams of dopa decarboxylase, which for many people is enough to completely inhibit it. The lower dose doesn't really gain anything for you. And then if a person has nausea from it, from some of the peripheral conversion, you're going to end up switching it anyway. The controlled release form, the standard controlled release form, is only a little bit better in terms of its duration of action than the immediate release. So CR is not that great a medicine. It tends to be absorbed more slowly, less reliable, and has only about 75% of the bioavailability of the regular formulation. So if you switch somebody from immediate release 25-100 to controlled release, they are getting less medicine. And so you shouldn't be surprised if they complain that their Parkinson's symptoms are not as well controlled. There's also an orally disintegrating form called Parcopa. It does not actually work any faster than regular Cinemet. And so the rationale for using this is if a person has more advanced Parkinson's, has trouble swallowing the pills, the rapidly dissolving form will allow it to dissolve under their tongue, and then they may be able to get it down more easily. Or you can crush it, right? Okay? All right, so what would be really nice is to know for patients who are started on an agonist or levodopa, what is the long-term outcome? And for a long time, nobody really knew because the study was never done. But in the UK, they had been doing a study for over a period of 10 years, from 2000 until 2009, where they ran an open label trial of 1,600 patients newly diagnosed with Parkinson's disease. The way that this study ran, if a person was diagnosed with PD, the study investigator would call this coordination center, and they would be told over the phone what to start. It was open label. Both the subjects and their doctors knew what they were on, but all it did was it was registering them, kept the distribution between medicines, levodopa, dopamine agonist, and an MAO inhibitor fairly even. And the outcome measure was a self-reported outcome measure. So it was based on a questionnaire. It was not based on an exam. But again, getting to the idea that the goal of using treatment is to try to improve patients' subjective quality of life. So this is the results of the study. The top graph here compares levodopa with the levodopa sparing agents. So this is just the initial treatment. By the end of the study, there were many subjects who might have switched or were on some combination. So this is just shown based on the initial treatment assignment. And what you see is that for the entire period of the study, there is a slight difference between those patients who were randomized on levodopa and those who were on other agents, where levodopa was slightly better. Now, even though this was statistically significant because of the size of the study, it did not meet what their cutoff was for what was actually clinically meaningful. So what it tells us is that at least the way that this study was done, in terms of its effectiveness, really no big difference. This graph here in the bottom left shows dyskinesias. And like the previous studies, the patients who were on levodopa in red had a higher risk of developing dyskinesias early on, but at the end, they were more similar. And some of the long-term follow-up from those early agonist versus levodopa studies have shown similar results. Even though at the end of the trial period, there was a clear difference, if you follow patients for longer periods of time, by the end, there may not be that much of a difference between levodopa and agonists in terms of their likelihood to cause dyskinesia. This last slide shows dropout. So of those that were originally prescribed MAO inhibitors, by the end of the study, almost 3/4 of them weren't on the MAO inhibitor anymore. And for agonists, about 50% of the patients were off agonists. Part of that may be, probably is largely driven by side effects. Whether some of that is driven by cost or other factors wasn't really taken into account in the study. Almost all subjects that were started on levodopa remained on levodopa. So I think the way that I would interpret these data is that there are some reasons to think about using an agonist first for younger patients who have no comorbidities, because at least in the shorter term, over the first 3 to 5 years, it does seem to result in a lower risk of dyskinesia. But if you follow the patients for a longer time, by the end, it really probably doesn't make that much of a difference. So even if you feel like you have a good justification to start an agonist, if a patient is starting to complain of side effects, you shouldn't worry about having to switch them to a levodopa. All right, so next case. This is a 58-year-old right-handed attorney who has had Parkinson's for quite a few years, initially diagnosed with a left arm tremor, had gradually developed some problems with bradykinesia. It was treated with pramipexole, with later addition of carbidopa levodopa, and up until the last year, medications were working pretty well for him. He takes 1 milligram of pramipexole and Cinemet 25-100, 1.5 tablets TID, and his complaint today is that his medications don't seem to be working as well. Okay, so this is now a patient who's had established Parkinson's disease that's dopamine responsive, but is now starting to have less than optimal control of his motor symptoms. What you want to know is you want to know what symptoms he's experiencing and when they're occurring relative to his doses. You want to be sure to know when and how regularly he takes the medications. Many of the medicines we've talked about have fairly short half-lives and short duration of action. And so if a person is taking the medications every 8 hours, it's very different than a person who's taking TID dosing where it's every 4 hours during the day and then they go overnight without any medication. You also want to know what side effects they're having with the medications, because that will have some bearing in terms of how you think about dose adjustment. So the approach that I take is when a person starts to complain of motor fluctuations, I usually ask them to walk through a typical day with me. Find out what time they wake up, find out how their motor symptoms are in the morning when they're likely to be at their lowest in terms of their dopamine levels, and then try to identify patterns of response fluctuations. So this is a graph that shows what a typical person might experience over the course of the day. At the beginning of the day, when they haven't taken their medications, they may be more bradykinetic, more stiff, be off, and then they take their medications, and then after about half an hour or an hour, whatever it may be, they start to have improvement in their mobility. After a period of time, and that may be 2, 3, 4, 5 hours, if they were to miss a dose or not take their dose with a reasonable dosing interval, the symptoms would start to return, and then they would reach an off period, and then they get these fluctuations. And so in a more advanced Parkinson's patient, one of the goals is to try to smooth out these motor fluctuations as much as you can. It's very difficult for people to have to fluctuate between feeling like they can move and then feeling like they're off, because it really affects how they plan their day. So these are some of the choices, and you can either adjust the pramipexole dose or switch to an extended release form. You can try going up on the carbidopa levodopa. You can change the medication doses to 4 times a day and move them closer together. You could add a COMT inhibitor or an MAO inhibitor, or probably the answer is any of the changes would probably help. So you have quite a lot of different options in terms of trying to make dosing adjustments. And here what you're trying to do again is you're trying to get benefits in terms of their motor response with minimal side effects. And so if one doesn't work, you switch to another one, and you can try any of these. So these are some of the treatment options for end of dose wearing off. You can shorten the dosing interval. If a person's wearing off at 5 hours and you can give them their next dose at 4 hours, you'll catch it before they reach their off period. You can increase or add the agonist. If they're not on an agonist, you can add it. Presumably there was a reason why this patient wasn't on an agonist in the first place, not this particular one, but your patient. And so you want to keep that in mind. Or if the person is on a regular agonist, you could switch to an extended release agonist, taking advantage of the more prolonged and steady pharmacokinetics. Or you can add an enzyme inhibitor. So getting to those last issues, this is just a reminder of the levodopa metabolism. When you take levodopa and it gets into the blood, without an enzyme inhibitor, much of it would be converted or broken down in the periphery before it's able to cross the blood-brain barrier. Carbidopa is a dopa decarboxylase inhibitor, and that prevents the peripheral conversion of dopamine. But levodopa can also be broken down by COMT. And so if you give a COMT inhibitor like entacapone, again, you preserve the active levodopa species that can get across the blood-brain barrier and made into effective dopamine. Entacapone is interesting because it actually itself never crosses into the brain. So all the effects of entacapone are actually all peripheral. So there are a number of studies that compare um, or add either an MAO inhibitor or a COMT inhibitor. I've just shown you one study which actually compares the wrong word. It actually used both medications, but it was only powered to compare it with placebo. So this is looking at reduction in off time. So if a person, based on a diary, has a certain number of hours of off time during a day, and you add this medication, the question is based on that report, whether or not there's any improvement. And this was a fairly large study of 200 some odd patients in each group, followed for a period of 18 weeks, and both visagidine and entacapone were effective in terms of reducing your mean daily off time compared to placebo. So for somebody who is on medication, on carbidopa, levodopa, with or without an agonist, you can add one of these enzyme inhibitors. The dosing is different. With entacapone, you add 200 milligrams to every dose of the carbidopa, levodopa. Doesn't matter whether or not the person's on half a tablet, one tablet, or two tablets of levodopa. You always add the same amount of entacapone generally. Azilect is just given a once-a-day medication. Okay, so 1 year later, you get the report that he's getting from one dose of medication to the next pretty well, but his wife thinks that his shaking is worse. So at this point, what you've done is you've increased the dose of agonists, you've spread them out a little bit more over the day. In addition, you've increased the numbers of doses of carbidopa, levodopa with addition of entacapone to each dose. The main question is to think about and get a description of the types of movements. Here we're referring really to the development of levodopa-induced dyskinesias, and there are many patients and caregivers who talk about involuntary movements and lump them all together. And it's important to distinguish whether or not a person is really having more tremor, which is a symptom of their Parkinson's, or whether they're having more dyskinesias, which are a side effect of their medication. Oftentimes, dyskinesias will be more pronounced shortly after they take the dose, or later on in the day after they've taken a few doses. Tremor tends to be most noticeable when the medication is wearing off, so at the end of a particular dose, or maybe when they first wake up in the morning before they've taken their medication. So the data for amantadine as treatment for levodopa-induced dyskinesias is not very strong, but it's the only medicine that's available which seems to have this effect. This was a double-blind randomized crossover study where some subjects took amantadine for 3 weeks and then were off of it before taking the other one, and the other ones were vice versa. And these lines reflect each individual patient. So what you can see is that most of them, when they took amantadine, they had improvement in their dyskinesias. One patient nearly had resolution of the dyskinesias. There were a few patients where the dyskinesias didn't get better, or some even got worse. But overall, at a dose of 100 milligrams twice a day of amantadine, there did seem to be some improvement in dyskinesias. This is another trial, which was, again, a double-blind crossover study that was published more recently. And this, on the left, is a subjective rating scale of how much the dyskinesias improved. And what you see is that placebo, the majority of patients didn't have any change. With amantadine, there's a shifting towards the left, which is improvement in dyskinesias, and you see that graph here. So when you see a patient with dyskinesias, the first thing to ask yourself is whether or not there's any role to reduce the amount of dopamine replacement, because if you can do that, that may reduce the dyskinesias. Problem is that some patients require that much medication in order to be able to maintain their on state, and so just trying to add amantadine may be your only other option. Now, there are a couple of new formulations of levodopa that have been FDA approved within the last 4 months, and so I'm just going to mention them here. One of them is another form of carbidopa levodopa, which comes as a capsule, and the capsule contains beads that are formulated both to have a very quick, immediate release component, and others which are designed to release more slowly. You achieve peak plasma concentrations using this Rytary after an hour. The biggest difference is that the maintained plasma concentration is much longer than any of the standard formulations. So this is a graph that was in a report that was just accepted, put out by the company. And so what you see is that regular carbidopa levodopa here in the square peaks at about an hour, and by the time you get out a few hours, is there any way to use this? Okay. By the time you get to about 3 or 4 hours, there's very little left in the blood. Now that doesn't mean it doesn't work anymore, but what it says is that it's the plasma levels are not very constant. If you use the accepted CR form, which is the controlled release form, it's really not all that much better than regular. And if you add entacapone, it's a little bit better than that, but still not great. This Rytary form has a much more extended a constant level of levodopa in the blood, lasting about 4 or 5 hours. So based on that rationale, one would think it should be good. The dosing is completely different. So if you're going to think about switching somebody to Rytary, it's not a one-to-one conversion by any means. And so there's an algorithm that you use for dose conversion. But I think that for patients who are starting to have fluctuations and where you can't manage the symptoms adequately, I think that this is one option. There is another form of levodopa that's now FDA approved, which is delivered as an intestinal gel. So here, a patient will actually need to have a special PEG tube placed that's extended into the jejunum. The intestinal gel is delivered through a pump shown here, and you give an initial morning bolus, and then the infusion is given continuously for a period of 16 days. Based on the delivery mechanism, one would expect that you should be able to achieve fairly constant levels and good control of motor fluctuations. The downside, which is obviously a big downside, is that the patient has to have a J-tube in. So these are really for people who have failed other therapies, and we're actually looking to start some of these Duopa tube placements here at Mass General. So some of these patients will probably be admitted to RDA for overnight observation and to start their titration. So when you're on service, you might see some of these patients, and this is the rationale why. Okay, so the approaches to managing peak dose dyskinesias in advanced Parkinson's disease include changing to smaller, more frequent doses of medication. The extreme of that is using the Duopa, which is continuous. You can consider this alternative levodopa formulation, trying amantadine, or this is the group of patients where you would think might benefit from deep brain stimulation surgery. A number of trials that compare best medical treatment for DBS suggests that in a carefully selected population of subjects, DBS provides better motor control and better quality of life. But DBS is not without some side effects, and so you have to think carefully about whether or not those side effects, how those balance out given a person's sort of pre-surgical state. Okay, for the sake of time, I'm actually going to skip the last talk, the last case, except these are some strategies to deal with dopamine-induced nausea. Some patients will take fairly low doses of levodopa and not be able to tolerate them due to nausea. Even though 75 milligrams of carbidopa can be effective for many people, in some cases it's just not enough. And so what you can do is you can give more carbidopa for the same amount of levodopa, and that can sometimes help to alleviate dopamine-induced nausea. You can also switch to the controlled release form. Now, as I told you before, you give up some in terms of the potency and the effectiveness, but the fact that the onset is slightly more delayed will sometimes help to reduce the nausea and lightheadedness that some people get with the regular form. And if they're on an agonist, switch them to levodopa. If a person has, I've never seen a patient who had nausea in response to levodopa who then were able to tolerate an agonist, because that's likely to cause more nausea than anything. All right, so I'm actually going to stop. Last case was mostly about non-motor symptoms. But just to conclude, when you're seeing a patient and adjusting medicines for Parkinson's, be sure to listen to your patient. The treatment is geared towards improving quality of life, and unless you know the effect that the symptoms are having on their day-to-day activities, you don't really know what your goal is in terms of trying to adjust medicines. The timing and the dose of medicines are equally important. Don't overlook one for the other. And just work with your patient, because there's no single right way to treat PD. But with all of the effective medications that we have, you really can make a huge difference in terms of somebody's quality of life. So I'll stop there and take any questions.
So we have heard you often say that gait is indeed responsive to the so when you have a gait, is there any way to say that you just keep pushing up over both?
No, so the question that Shamik had was in relate to gait symptoms and medications. So in general, axial symptoms of Parkinson's disease, including gait or hypophonia, tend not to be as responsive to medications. So when you're assessing somebody who's having problems with their gait, if the issue is related to bradykinesia, so if they're having trouble because they're dragging one leg, for instance, trying more medication can be helpful. If the problem is postural instability and balance issues, higher doses of medication are unlikely to help and may actually cause more harm. So you want to try and gauge, as you see the patient, what it is that's contributing to their gait problem. If the issue is that they're dragging their leg, probably more medicine helps. If the problem is that they're reporting to you that they're having falls, more medication will probably not help. You can try to refer to physical therapy, but these gait issues and postural instability problems can be very hard to treat. And when patients get to that stage, they just become much more difficult to manage than when you're just dealing with bradykinesia and rigidity. Okay, thanks very much.